Good evening, everyone. I am Dr. Ioana Menzelopoulou, NISDA DNI Chair, and I'm excited to welcome everyone to our webinar, Improving Patient Care Through Cultural Awareness, Clinical Communication, and Inclusion in Dentistry. The purpose of this meeting is to provide an opportunity for us to get together virtually and share perspectives, concerns, and strategies for your everyday practice of dentistry. NISDA's DNI Task Force supports equitable, safe, and high-quality patient care. We are grateful to our sponsors for making this webinar possible. Alfest Personal Wealth Management, DDS Match Professional Practice Transitions, Madelbaum Barrett PC Relationship-Based Legal Services, and Care High Dental Referral Platform. Thank you for supporting NISDA's diversity and inclusion initiatives. At this point, I would like to introduce you to our program moderator, Dr. Fabiola Milord. Dr. Milord obtained a Bachelor's of Science from St. John's University, followed by a Doctor of Dental Surgery from New York University College of Dentistry. She completed a general practice residency at Metropolitan Hospital Center and a dental oncology fellowship at Memorial Sloan Kettering Cancer Center. Driven by the need to emphasize oral health as a basic human right, Dr. Milord went on to obtain a master's degree in public health from NYU's School of Global Public Health. She has since been invited to speak to a variety of organizations, including the American Dental Education Association, as well as Columbia University's Mailman School of Public Health. Her many awards include the 2025 Faculty of the Year Award from Long Island Jewish Medical Center, the 2022 Humanitarian Award from the Academy of General Dentistry, and a Doctor of Humane Letters from Adelphi University. She maintains a private practice in New Hyde Park, New York. Her office brings together the totality of her experiences as she continues to provide quality patient care. Dr. Milord.
Thank you very much, Dr. Menzelopoulou. Much appreciated. Thank you for that very nice introduction. Good evening, everyone, and welcome. Thank you for joining us for tonight's webinar, Improve Patient Care Through Cultural Awareness, Clinical Communication and Inclusion in Dentistry. Special thanks to NISDA for hosting this event, and thank you to Dr. Menzelopoulou for allowing me to be the moderator of tonight's session. As clinicians, we strive for diagnostic accuracy, clear treatment planning, and predictable outcomes. Yet, we all recognize that even the best clinical decisions can be compromised when communication barriers exist. Cultural and linguistic factors influence how patients report symptoms, express pain, understand risk, and follow postoperative instructions, directly affecting patient safety and treatment outcomes. Tonight's program takes a clinical, evidence-based approach to these challenges. Our speakers will focus on how communication gaps can contribute to misdiagnosis, compromised informed consent, anesthesia and surgical risks, and reduced adherence to treatment compliance. Through clinician-led narratives and case-based discussion, we will explore practical strategies that can be implemented in everyday practice. Our presenters bring diverse clinical experiences and will share real-world examples where recognizing and addressing cultural differences, improved diagnostic clarity, strengthened patient trust, and reduced clinical risk. The goal is for us to come out with actionable tools that enhance assessment, communication, and patient outcomes across diverse populations. This program includes interactive discussion and a live Q&A. Feel free to drop your questions into the Q&A function. Most importantly, please complete the post-event survey at the conclusion of the program to receive your continuing education credit. The survey will come up at the end of the webinar. With that, it is my pleasure to begin tonight's program and introduce our speakers in order of their presentation. You are looking at Dr. Ivan Vasquez, DDS. Dr. Ivan Vasquez is a native of San Juan, Puerto Rico. He received his Bachelor of Science degree from the University of Puerto Rico and his DDS from the New York University College of Dentistry. After completing his residency and 1 year as chief resident, he received his pediatric certificate from Interfaith Medical Center in Brooklyn, New York. He is currently an associate in the private practice he established for children and adolescents in Hauppauge, New York. For more than 30 years, he has been a pediatric dental attending at St. Barnabas Hospital in the Bronx. Dr. Vasquez is an active member in organized dentistry. He is past president of the Suffolk County Dental Society and one of the founding members and past presidents of the Puerto Rico Dental Association right here in the USA. He is a fellow of the American College of Dentists, International College of Dentists, and a member, past officer, past trustee of the Hispanic Dental Association, the New York chapter. He has served as Suffolk County delegate and alternate delegate to the ADA and a delegate and alternate delegate to NISDA's House of Delegates. Dr. Vasquez is also a member and past chair of the NISDA Diversity and Inclusion Task Force and current chair of the Greater Long Island Dental Meeting. NISDA is proud to welcome Dr. Vasquez. Dr. Vasquez, the microphone is yours.
Thank you very much, Fabiola, and thank you for this opportunity for me to tell my story. As part of this webinar of improving patient care through cultural awareness, I was asked to do this, and it was a great opportunity, like I said, for me to tell my story. I always wanted to be a dentist. Ever since I was growing up in Puerto Rico, I looked up to my neighbors and my parents' friends, and I wanted to do what they were doing. I wanted to be a dentist. I applied to dental school in Puerto Rico, where only 40 students get in twice. After the second time that I didn't get in, I was like, forget dental school. I am not going to do this. And I was kind of like discouraged about it, but I went on. I got married. I went to work. And when I was working, I was also a volleyball and coach referee in Puerto Rico. I always say that if I stayed in Puerto Rico, I would have become a referee going to the Olympics. But I think now it's better off to go and buy tickets to go to the Olympics. I think I made a great decision to pursue my career in dentistry. After 5 years of working, one day my parents asked me if I still wanted to go to dental school. This was on a Wednesday night. I was working. I was already established in my work. And I said to my parents, sure, whatever you guys want to do, if this is what you want me to do, I will go and get to dental school. Remember, this is 5 years after I took my DATs and after I had submitted all my paperwork and everything else. 5 years of not having to study, not having to be worried about, taking tests or anything like that. When I spoke with my parents, this was on a Wednesday night, and they said, as part of a federal program right now, they are taking minority students in most of the schools in the United States. So be prepared that maybe you will be going to school at Marquette University. I was like, Marquette University, way too cold for this island boy to go to Marquette University. But this was their wish to have me go to dental school. The following day, I go to work, I'm on my route, and as I'm visiting one of the hospitals that I used to visit, I get a phone call that I had to call the office because my parents were looking for me. This is a time when there was no cell phones. So it was just getting back on the phone and calling my parents. I called my parents. My father said to me, "You are accepted at NYU College of Dentistry and you are leaving tonight." This phone call came in at noon. They said to me, "We are going to the bank to get the tuition money, and you have until 7 o'clock tonight because we got you a flight to go to New York tonight." I'm like, wait a second, quit my job, go pack and go. Wait, what? No, I can't do this. My parents said to me, "You will do this. We already did all the paperwork and everything, and you're leaving tonight." So I proceeded to go over and go to my boss and quit my job, pack. And by that time, they had changed my flight for midnight. Now I'm getting to New York at 3 o'clock in the morning. I don't know anybody in New York. I speak to the cab driver at the airport. I need a ride to the city, drops me off at some hotel in the city. And 8 o'clock in the morning, I'm at NYU with my luggage and ready to submit all my paperwork and everything. This is Friday before Labor Day. Already, the whole class has had their orientation and everything else, and everybody's ready to start school on Tuesday morning. While I'm there, they asked me if I had a place to stay. Absolutely no, I don't have any place to stay. I just got to New York and I don't know anybody in New York. Well, while I'm there, a phone call came in from somebody that had dropped out of the incoming class. And all of a sudden, there is an opening at the new dorm at NYU. At that time, it was the new dorm, the one on 25th Street. Right now, it's kind of old, but it was the NYU dorms. By Saturday morning, I wake up in this apartment that they had gotten me, or this room, and everything went so fast that all of a sudden I'm like, where am I? What am I doing in New York? I'm in a completely foreign place. I don't know what's going on. I come out, I call my parents, I had to walk to a payphone on the corner because, again, no cell phones. And I proceeded to tell my parents, I'm going back to Puerto Rico. I'm giving everything up. By the time I get back to Puerto Rico on Tuesday, I have my job back. My parents were completely adamant about it and explaining to me and trying to get me to understand that this is a one in a million opportunity that not everybody gets. After that, they proceeded to send my brother to convince me to stay in dental school. My brother came in 10 years older than me, not a dentist. He goes with us to the anatomy department. At that time, they weren't checking to see who was going into the anatomy. And he proceeded to do dissections with us during the session that we had. And he said to me, "Why don't you go back to Puerto Rico and I'll take your spot over here and I'll become a dentist." By that time, I had already decided to stay and to complete my 4 years of education. I proceeded during this time. I met my wife. She was in my same class, soon to be my wife. We got married today, 37 years. Happy anniversary to us. We established our practice. We've had 4 children and a son-in-law and a daughter-in-law, which both are great to our kids. Once I started working, I noticed that I wanted to work in underserved areas. So one of my first jobs was in the Bronx, and I wanted to work in the Bronx to take advantage of the fact that I am bilingual and I could take care of the underserved population in the Bronx. Eventually, I opened my practice on Long Island in an area that is, I would say, 90% Spanish for the same reason. I wanted to help the people in my area, help the patients in my area. I decided also to go and do my boards in Puerto Rico to have my license in case I decided to go back at any point. I wanted that option open. To my surprise, one of the examiners in the oral surgery part of the boards was the former dean of admissions at the University of Puerto Rico School of Dental. And I aced that part. And he turned to me and he apologized for not taking me in the school in Puerto Rico, which gave me a lot of, good feelings about it. So after that, I decided when I opened my practice on Long Island, I decided to become an area representative for the Suffolk County Dental Society. At that point, there were area representatives that we had. And it was just to work to improve my profession in the area, to help the dentists that were in Suffolk County and become a better dentist myself. I joined the board in Suffolk County and eventually was president of the society, being the first Latino president that Suffolk County Dental Society had. I worked my way up as a treasurer, secretary, vice president, president-elect, and president. I have been a delegate, like my bio said before, to a state society and to a delegate to the ADA. I've served in many communities, again, trying to get better things for our fellow dentists. As far as teaching opportunities that I had, as I finished my residency, I started teaching at NYU during the day and during the evening program. The evening program was designed for international students. That's when I met our current NISTA president-elect, Dr. Amarilis Jacobo. Shout out to Amarilis. She was my student. Eventually, I started teaching at St. Barnabas Hospital Residency Program, where I have been for 34 years. I've taught multiple residents, including the current co-directors, Dr. Paul Chu and Dr. Rebecca Tanning. They were both my residents. I've taught many other pediatric dentists, and some of them I have hired as associates when I had my practice. Some of the clinical challenges that I got when explaining to the parents the different treatment plans that we had. First of all, I would have to try to teach them for their children proper hygiene and to break some cultural habits to benefit the children. The majority of the patients that I treat are 90% Spanish. The majority of them by age 1, they're still, putting the kids to sleep with the bottle. By age 2, they're putting the kids to sleep with the bottle. And sometimes even by age 3. So we have to teach the parents to take the bottle away by age 1. Why? Because anything that contains sugar, like the milk and the juice that they put in the bottle, when they put them to sleep with the bottle, this can cause cavities. And a lot of pushback that I got from the parents was that, well, my other kids, this didn't happen. So you have to tell them, listen, not everybody has the same bacteria in the mouth. So your other kid, maybe this didn't happen, and he was lucky that he didn't get cavities. So we have to teach them and instruct them on to take the bottle away by age 1. Also, this is another thing that the pediatricians don't tell them, because many times I ask the parent and I said, did the pediatrician tell you about this? No. So it has to be us that tells them, and also to have them brush their teeth. Many times they say, we don't have to brush their teeth. Those are baby teeth and they're going to fall out. Yes, they're going to fall out at some point, but a lot of times you have to keep those molars to preserve the space for the other teeth to come in. And you have to explain this to the parents. A lot of times the parents don't understand what you're trying to explain to them because they haven't experienced that yet. Sometimes it's their first child, and you have to tell them and give them proper education. Another thing that I always did when I was treating my patients is what I was explaining to them what the procedure was that I was going to do. If I was doing a stainless steel crown, I would show them what the stainless steel crown looked like, because you're going to get pushback on that. Oh my God, but that's a metal that's sitting in there. Yes, it is metal, but this is the reason why we're doing the stainless steel crown. Because when you go ahead, you do a pulpotomy, you're weakening that tooth. Now you have to put a restoration there that would last and you don't break the tooth. So that's one thing that I always had to explain to them, and I always did. What I would do was on their chart, I would draw what was going on. I would draw a tooth and I would explain what I was doing, and I would explain why we would have to do that. You know, in order to prevent pain, in order to prevent swelling, loss of space, like I said before, and visits to the emergency room. Because once the kids have an abscess, they're going to end up in the emergency room and they're going to have time that they're going to miss from school. A lot of the parents deny the medical condition that their kids have. So you have to take a very thorough medical history. Observe the child when you're talking to the parent. Observe for any type of speech delay, for any type of other problems, eye contact, all these things that will give you some ideas on how you're going to treat the child and how your treatment is going to be and your behavioral management is going to be. That will tell you if you're going to do the treatment in the office or if you have to rely then on some type of sedation or maybe taking the child to the operating room to do the work. One thing that we always had in our practice was we had our medical histories and our consents in Spanish and in English, as well as you have the translation services that you can take advantage of. But always make sure that you explain everything to the parent and the parent understands you. For me, it was kind of easy because I am bilingual, but a lot of times you have to rely on the child to explain to the parent. No, it's not good. So you should have somebody there, an adult, that can explain to the parent what you're going to do on their child. I always made sure, like I said, that I explained everything with drawings and with notes. And another thing was that I never compromise my treatment to please a parent because of aesthetics. If I believed that using an amalgam was the right treatment for the child, I would stick by my guns. My philosophy had always been to do definitive treatment and to do the best for my patients. Thank you.
Thank you, Dr. Vasquez. That was very thorough and very in-depth discussion about your journey and how pediatric dentistry is perceived in the population that you treated. So thank you very much. Much appreciated. Moving on to our next speaker, Emma Guzman. Dr. Emma Guzman graduated from the University at Buffalo School of Dental Medicine and did a general practice residency at Bronx Care. She is a New York City-based general dentist, speaker, wellness educator, and founder of Vibrant Empowerment by Emma LLC. She blends clinical expertise with leadership, storytelling, and culture to help professionals elevate their well-being and performance. As a speaker and consultant, she designs experiences that center joy, intention, and professional growth. NISDA is proud to welcome Dr. Emma Guzman. Welcome, Dr. Guzman. The microphone is yours.
Good evening, good evening, good evening. I am so happy to be here. And thank you for all of the attendees that are here and that are spending their Wednesday evening with us. It is much appreciated. This is such an important topic, and I'm glad that you're here to learn from NISDA. So, like I said, thank you for the opportunity to speak on a topic that sits in the intersection of clinical excellence, culture, humility, and health equity. When we talk about diversity and inclusion in dentistry, we're not just talking about abstract ideals, we're talking about lived realities. And our patients go through these lived realities every day, and there are measurable disparities that continue to shape the outcome in Black communities. So, before I go into my story, I just want to ground the conversation in data. Black adults experience untreated cavities at nearly twice the rate of their white counterparts, 40% versus 21%. And among older adults, untreated decay is 3 times more common in Black adults, which is 28%, than their white counterparts, which is 9%. More than half of Black adults, 52%, have lost at least one permanent tooth due to decay or gum disease. And Black adults are at least 2.5 times more likely to visit the ER for a dental issue. And that's often because they don't have a dental home or they don't have insurance that they're able to depend on and use regularly. And we know not only in the Black community, but in many communities that are underserved, dental decay and tooth pain is one of the main reasons why people miss school and why people miss work. So we need to make sure that us as providers take care of our patients, find out what's really going on at home. We have to talk about diet. We have to talk about transportation because there's so many different things that stop them from getting care. It's not just access. Access in the sense of, okay, do you have a dentist near you? It may be the fact that they can't come into the office because they don't have childcare. They can't come into the office because they can't take off of work. So these are more things that we need to dive into when we're treating certain populations. And these disparities, they don't happen in a vacuum. They're shaped by cultural factors and systemic inequities. And we have to be able to communicate with our patients as providers, build trust, and deliver care. So now I want to talk about who am I, right? And why am I speaking about this? So as Dr. Mulord already mentioned, my name is Dr. Emma Guzman. I am a Garifuna American dentist whose family immigrated to the United States from Guatemala. So culturally, I am Latina and Caribbean. Ethnically, I'm Garifuna, which is an Afro-Indigenous group that's originally from St. Vincent and the Grenadines. But racially, I am Black, and that is the way that I'm presented to the world, and that's what's at the forefront. I grew up in Brooklyn, New York. I always lived in a pretty diverse area. I was in Sheepshead Bay. I went to school in Brighton Beach, Sheepshead Bay, but a lot of students bust into the school. So I never felt like I was in an area that wasn't diverse. It wasn't until I started pursuing dentistry and my undergraduate education where I started really seeing some disparities in terms of how my population was seen. Even though I excelled in school, when I was applying to undergrad, I was told, oh, maybe you shouldn't apply to that school. You should apply to something safer. Maybe you shouldn't go into this. You should go into something that's easier to get into. And I was constantly deterred from pursuing dentistry, even though I was a straight A student. Then, once I was an undergrad, I went to the school that I wanted to go to, that I was told I couldn't get into, which was Rutgers University. I went there my first year, but then I did transfer out because the tuition was too high. But I had to prove a point and show the people that I could get into the school that you told me I couldn't get into. So after that, I went to the University at Albany, and I would say that going to that school absolutely impacted my educational journey. They had offices specifically for Black and Brown students. in STEM. So they started talking to me about volunteer hours, shadowing, all these things that I didn't know before that I had to do besides be a good student. And I went through my undergraduate career being in the pre-dental club, going on mission trips, being the president of multiple organizations, and still maintaining good grades and getting on the dean's list every semester. And when I got to the point of applying for dental school and I needed the pre-health committee letter, they wouldn't write me the letter because I did not take physics. Now, at this point, I was a junior, and that was strategic. I didn't take physics because it wasn't in the DAT. Like my whole undergraduate career and everything I did was very laser focused. And I said, I would take physics after I take the DAT. I wanted to complete all my classes that were required for me to prepare for that. And because of that, I did not get a pre-health committee letter. So I had to get individual letters for every single school based off what type of letter they wanted. But that did not deter me. I did what I had to do. And I got into my number one choice, which was the University at Buffalo. But when I went to Buffalo, I was the only Black student in my class. The only Black student in my class, one of 90. And I was one of the 3 Latinos. And honestly, that felt like I had the weight of my race in my back. I felt like I had to represent the race. I had to show up a certain way. And I really needed to be focused on gross anatomy and not all these other things. So it definitely impacted my first semester of dental school because I was so stressed out about not being in a diverse environment. And I had to go back to Albany and talk to my mentors there. And they're like, look, you know what? People are people. Connect with those people that you're in school with, and you will make it through. And it absolutely did happen. I had a great group of friends that I met in dental school that I was able to go through dental school with. And I graduated and I came back to New York City because I said Buffalo was a little bit not diverse enough for me. But the impact that I had in dental school was really in my public health class and in clinic. And that's when I first learned about the social determinants of health and how they pertain to dentistry. So I just wanted to go over the social determinants in case someone is not familiar with what they are. And there are non-medical conditions in which people born, grow, live, work, and age in. And there are broader systems that shape those conditions. So what does that mean? It's conditions that you cannot help. So the neighborhood you was born in, where you grow up, what you work. So where you work or where your parents work, those are not conditions that you could control. So that's what the social determinants are. And they influence health outcomes more than genetics or clinical care alone. So that's why we have to look beyond our clinical expertise when we're treating populations, because there are things that factor into it outside of what's going on at home and what can I do as a dentist for you. We need to think about the whole environment, the whole person when we're treating our patients. And these social determinants, it shapes the risk for disease, access to care, and overall well-being. And we know as dentists, especially spread throughout the United States, there is a huge access to care issue. This has been an issue for many years, but the problem now is that legislators and individuals that are not dentists are trying to make decisions about this. They're trying to bring other, expanded providers, potentially having more hygiene practices. We don't have that in New York, but there's those type of practices in other states. They're trying to find other providers to alleviate the access to care issue. And that's something that we definitely need to take upon ourselves to protect our profession and make sure that we are treating the patients that we can with the best care. And that could open up access. Because if people come to us, they come to us from different populations, different locations, if they know that we are great providers. I have patients at the practice that I work in that are coming from the Bronx. They're coming from Staten Island. They're coming from Long Island. So in terms of access, I am not in their area, but they are still coming to you because they know that you will treat them with care, compassion, and look at the whole person. So if we think about what populations seek care at dental schools, hospitals, FQHCs, is primarily the underserved population. And that's where I saw the benefit, the power of me being Latina and me being Black in dental school. I was assigned those patients who looked like me, and I was assigned patients who spoke Spanish. So I was able to definitely brush up my Spanish skills because I only spoke Spanish to my mom. Uh, and now I had to start speaking Spanish to my patients every single day. And in my learning of speaking Spanish, I held dental Spanish lessons for my colleagues because we had a huge Spanish population in Buffalo. So me and my other two Spanish speaking classmates would not be able to handle all our patients. So we were able to provide Spanish lessons for one, the students that have Spanish speaking patients, and two, for the students who went on the mission trips, as Buffalo held mission trips to the Dominican Republic every single year. So it's highly important to make sure in your practices you're able to communicate effectively with your patients. We're going to talk about communication more a bit later, but on this topic, when it comes to language, we have so much technology now that we could use in terms of AI, in terms of Google Translate, in terms of having actual translator boxes in your practices so that you can communicate with your patients. Now, just speaking the words is one thing. That doesn't mean that the communication is effective. But if you're able to share that language and communicate in the same language as your patient, it makes such an impact. And this benefit for the patient is one that you can't imagine because they could be going to providers. And if you cannot understand what they're saying, they could be going from one place to the next, not being able to communicate what they need, how they're in pain, and what's actually going on. So it's important to make sure either you have a diverse team so people are able to communicate, or you have those translating services in your office. So now I left Buffalo and I went to residency in the Bronx. And that was a beautiful experience because when I was in the Bronx, I was able to treat my mom, my brothers, my aunts, family, friends, because a large population of Garifuna people are in the Bronx. So people, I would be in the hospital on rotation and I would see my auntie and then they would come to the dental clinic soon after because they were like, wow, you work here? Okay, I'm going to come to the dentist now. And even that, just seeing a familiar face, seeing someone you know and you trust in that field, that brought them into the practices. And it's the same thing when it comes to your patients. We need to go to community events. That's a way that we could increase clinical outcomes. Go to community events. Let the people in your neighborhoods know who you are, right? And if you don't live in the area where your practice is, then you need to go to the community events where you work. So you're able to communicate with those patients effectively. You see them, they trust you, they know that you're a human being and you're not just the scary dentist. And then you could bring people into your practices. So working in the Bronx, I was able to see many Garifuna patients, also many patients who spoke Spanish, many patients who spoke like me, who looked like me, but I also saw how so many patients waited until they were in pain to seek care. Because one, they don't have the time. They're like, look, I can't take off work, doc. Now today is an emergency. And the only thing I could do for them is take out the tooth. Or that's when we started to realize what's going on with insurance coverages as an adult. You need a root canal, but your insurance don't pay for it because it's a molar. So now we have to have this conversation. Are we taking out this tooth or are we saving it? Do you have the money to save it? And that's when I really started to see disparities when it came to the underserved population. When in dental school, you didn't really have to pay attention to it. So administration handled that. You had your patients, you were able to take care of them, and you did what you had to do. But now when you're out practicing in the world, you start to realize how insurance impacts how you treat your patients, how you're the demographic, what neighborhood you're in, the type of insurances you take. So all of that goes into how we take care of our patients. And I've been blessed that I've been in the many practices that I've been an associate in, I have been able to work with diverse groups. I worked in Bushwick and Cypress Hills initially when I first came out of school. And same thing as the Bronx, everyone spoke Spanish. The majority of my patients were Dominican. And I was able to treat those patients and speak the same language. I also worked in Harlem. I worked across the street from Harlem Hospital, and I was seeing primarily Black patients at that practice. I worked in Park Slope, and I still work in Park Slope now, and that has been a diverse group of patients, Spanish speaking, a lot of transplants, people who've come from other states to New York City. And I would say this is where I've seen the most diverse group of patients. So I see on a daily basis Asian patients, European patients, white American patients, Black American patients, Caribbean patients, Latino patients. And that was impactful for me as well because it took me a bit out of my comfort zone to be able to know that it's not just about treating Black and Latino patients, it's also about treating everyone else and knowing, okay, what are the nuances? What are cultural things that happen in your practice with certain populations, right? There's certain especially with Asian populations, they take off their shoes, right? And there's certain things that go on that you start to notice with your patients that you don't see like, okay, that's odd. Why did they do that? There's certain things that show respect culturally, and we have to take note of those things as well, based off of the demographic that we see. So that's my story in terms of my journey. And now we're going to speak about how cultural factors influence patient comfort, pain reporting, and treatment decisions. So cultural context shapes how patients interpret pain, how they communicate discomfort, and if they feel safe asking questions. I'm going to repeat that. Culture context shapes how patients interpret pain, how they communicate discomfort, and if they feel safe asking questions. Many Black patients have lived experiences, personal or generational or historical, of being dismissed or undertreated in healthcare settings. So because of that, Black patients are more likely to experience discrimination in dental settings or just have the feeling that they're experiencing discrimination, even if it's not actually occurring. And why is this? This is because of the historical context of Black patients being experimented on, right? And we all know that history, right? That's generational, that's historical, things that happen in our country, things that happen in outside countries. And because of that, there's an inherent mistrust. And then now you have the added factor of the media, which doesn't help in the way that people see dentists in the first place, regardless of if you're Black, white, brown, or yellow. Dentists do not have the best reputation. So, what does this lead to? Underreporting of pain. Why are we underreporting our pain? We're underreporting our pain because we don't trust that you're going to do something about it. We don't think you're going to believe us. And there's hesitation to challenge a recommendation. And we could go into the cultural aspect of that, right? We have a fear of being labeled difficult, right? I don't want to be the angry Black woman. I don't want to be the aggressive Black man. So if my provider said something to me, I'm just going to go for it. I'm not going to say anything about it. But the issue that comes with that is they have poor experiences when they come to our practices. So how do we combat that? We have to normalize pain reporting. We have to say out loud, many people minimize their pain. I want to make sure I understand what you're feeling. We have to look at body language, right? Patients may say, oh, I'm okay. I'm not feeling anything. But we see them clutching their fists. We see their legs start moving. They start fidgeting when prior to that, they were calm. They weren't moving. So we have to make sure that we're looking at body language and not only just waiting for them to raise their left hand. Another thing that we have to do is ask open-ended questions. What concerns you specifically about this treatment? I have patients that have come in and told me, oh, well, my sister told me that this root canal is going to cause a heart attack. So we have to make sure that we're educating our patients because we have no idea what they're hearing in the media and what they're hearing at home. And we have to validate their lived experiences. We have to validate their lived experiences. We have to let them know that their comfort and their trust matter in our practices and that they deserve to feel fully informed and fully heard. And what are our strategies to improve informed consent and clarify post-op instructions? It's not just making sure we get that signature. We just want to make sure that we improve clarity and equity. We want to use plain language. We want to avoid the dental jargon that we're so used to using because we use it on a day-to-day. It's our language. For example, we want to say, instead of saying periodontal debridement, we're going to do a deep cleaning below your gums to remove the infection, right? We're going to do the teach back method. We're going to make sure that they understand what we just said to them, what we explained, by having them repeat it. I just explained to you what nerve treatment is, what a root canal is. Can you explain to me what's your understanding of that? Just to make sure they know exactly what we're doing. Using visual aids, images, models, and diagrams, it helps bridge literacy gaps and reduce anxiety. Sometimes we don't know what we think may be an easy word that people may not know. We want to be transparent about discussing risk. Yeah, you may have post-op pain, but this is why we're going to give you medication after. Because that transparency, it builds credibility. We want to make sure that they are very clear as to what we're doing. So now, how could we keep adherence and understanding with our patients? We want to do pre-visit phone calls and texts to make sure they understand what they're coming in for, especially for surgical appointments. I already spoke about the technology. We want to make sure that we have bilingual or culturally aligned educational materials in the practice, the use of technology for translation services. We may want to extend chair time for the patients that we know that are high risk in terms of comprehending. Or if they're anxious. If you're anxious, a lot of the times you're not listening. So we want to make sure that we extend chair time for those patients. We want to have follow-up calls, 24 hours, 48 hours later, to make sure that they understand that this pain is normal. Take the medication, understand that everything's okay, nothing went wrong. And if something went wrong, we could catch it early if we're calling our patients to make sure. And these adjustments reduce no-shows, it improves trust, and it just enhances our care. So what's our role? It doesn't mean that you have to be a Black provider to see Black patients. You have to be an Asian provider to see Asian patients. No, that's not what we're saying. what we're saying is that representation is built through staff diversity, community partnerships, inclusive imagery, and culture competence. So this is a part of your training when it comes to that culture competence, and you will take that to your practices and when you're seeing your patients. Thank you.
Thank you very, very much, Dr. Guzman. I thought that was a nice dive into your background. And what I look forward to in the discussion is my challenge as somebody who speaks Haitian Creole has always been taking terms that I learned in dental school and in English and trying to find the appropriate terminology in French or in Creole. So we can dive into that after Dr. Tang's presentation. Let's talk about it a little bit in the Q&A to see how we figured that out. Because that's still a challenge, by the way. So you learn everything in English, but you still have to make it work for the patient's language. So thank you. Our final speaker is Dr. Vera Tang, and her bio is as follows. Vera W.L. Tang, DDS, MS, FICD, FACT, is a clinical assistant professor, vice chair, and director of predoctoral periodontics in the Department of Periodontics and Implant Dentistry at New York University College of Dentistry. She actively serves on numerous college and university committees, including the Admissions Steering, Senior Academic Leadership Team, NYUCD Alumni Association, NYU Alumni Association, Faculty Senators Council, University Senate, and as faculty advisor to the American Student Dental Association. Dr. Tang has received several accolades, including the American Academy of Periodontology Educator Award in both 2012 and 2014. She is a member of the distinguished honorary societies such as Omicron Kappa Upsilon OKU, the New York Academy of Medicine, the International College of Dentists, and the American College of Dentists. Dr. Tang earned her Doctor of Dental Surgery degree with honors from New York University College of Dentistry and completed her certificate in periodontics and master's in dental science at the University of Florida College of Dentistry. She is a diplomate of the American Board of Periodontology. In addition to her academic roles, she maintains a private practice in New York City, specializing in periodontics. Dr. Tang is an accomplished lecturer, having presented at regional, national, and international stages on various dental topics. She has also been a regular guest on Sirius XM Dr. Radio and has been cited in health magazines and websites. Beyond her clinical and academic contributions, Dr. Tang has been an advocate for organized dentistry since 1998. She has held leadership roles in numerous organizations, including the American Academy of Periodontology, American Dental Association, American Dental Education Association, American Student Dental Association, Nassau County Dental Society, New York County Dental Society, New York State Dental Association, and the Northeastern Society of Periodontists. Dr. Tang is a past president of the Northeastern Society of Periodontists and the NYUCD Alumni Association. She is currently serving as president of the New York County Dental Society. Dr. Tang, we are really lucky to have you because you are so busy. We appreciate you being here. Thank you so much. Dr. Tang, the microphone is yours.
Thank you so much, Dr. Millord, for the kind introduction. So as of last night, I am now a past president of the New York County Dental Association. So that is now behind me, and I look forward to the celebration in 2 weeks. So as a periodontist, we want to talk about why culture and language matters for periodontal care. Periodontal disease is largely asymptomatic until it's pretty much in advanced stages, which is problematic when we communicate with our patients. So in interpreting the disease and building the trust in the diagnosis and treatment of the disease becomes a challenge, not only for the Asian American population or ethnic population, but as well as for any patient. So oral health doesn't just affect the teeth, it has significant impact on the overall health, as we've been hearing in the news, and as there's been increasing links to diabetes and cardiac diseases, as well as Alzheimer's. The list goes on, and it's growing exponentially as the research is continuing. But tooth decay, caries, missing teeth, periodontal disease all cause a considerable amount of pain and low self-esteem, and can affect quality of life for our patients. So that's why poor oral health has a disproportionate impact on the racial, ethnic minority populations who have limited English proficiency populations and the low income population. So the Asian Americans in the US is one of the largest growing populations. 24 million is the last count in 2022. But their cultural beliefs influence their perception of bleeding, tooth mobility, and pain. And their attitudes towards surgery, tooth loss, and decision-making comes into factor when we talk about the barriers on explaining the risks of periodontal disease, whether it's the symptoms that they're describing, or understanding the disease progression, or why we need to do surgery, informed consent, post-op care, all of these factors into linguistics. So we want to, clinical excellence alone is insufficient without having a nuance in cultural and linguistic effective communication with our patients. So when we address diagnosis and treatment and symptom reporting for our patients, we want to think about how the patients would perceive this. So bleeding gums or abscess may be normalized in certain cultures as a sign of too much heat in my culture, or as a normal sign of aging or brushing too hard. So bleeding might be normal in those situations, or they've learned to believe to be so. In my culture, oftentimes my mother or my family member will ask me to drink some cooling tea or drink some cooling tonics because, I'll make the ulcer go away or the abscess go away. And, as I've been educating them through my career, it's, I'm finally making a slow turn and an impact on my family. But oftentimes if they have an abscess, they go straight for the tonic and the tea without coming in for an x-ray, which is unfortunate. So, slowly I'm trying to turn the waves for my family alone. The lack of terms also becomes a challenge, as Emma had mentioned. Periodontal disease, bone loss, chronic inflammation doesn't necessarily have a straight translation. So the literal translation might be very scary or very obscure. For example, periodontal disease in Chinese is directly translated into generalized disease of the teeth in the mouth. And that's very, very vague, and it could be many, many different things. Whereas a SRP or a deep cleaning is literally translated into diving into the abyss, cleaning around the teeth. So, it's pretty frightening as you think about these terms. And I don't know who came up with the names, but, it's quite imposing. So oftentimes, as in a position of authority, patients might be, uncomfortable saying no to you or asking more questions. So oftentimes they may say yes just out of politeness and not necessarily understanding what the treatment is or what the diagnosis is. So it's really important to take the time to explain the risk of disease, the progression, and, sometimes with incomplete medical histories, it puts a monkey wrench in the whole situation. So as we move on to the next step in obtaining the challenges and discussing the challenges of discussing medical history and informed consents, some barriers could be just being good historians. Many of our patients are not very good medical historians of their own medical history. Whether it's cultural reluctance and they're shy to admit as to what kind of disease they have. I had a patient that walked into my office who, after some prodding, finally told me that he was a pre-diabetic, and he told me he was not taking any medication. However, he was prescribed 2 different medications that he was not taking because he was feeling okay. So there's a lot of things that we need to consider. Or if the patient's taking traditional Chinese medication, where they're taking these tonics that often can affect bleeding issues in a surgical procedure. Some consent challenges that we might encounter is, I often encounter decision-making not only made by themselves or their parents, but they may bring in a decision-making person in their family, whether it's an elder or a spouse or a brother or sister, depending on the situation. Or they may view consent as a formality rather than a decision point. So it's important to take a look at the whole picture and sort of feel your patients out and see what their communication skills is, and how, and determine who is the decision maker in their dynamics in their family. Some risks that may impose on us if we don't take a complete medical history is anticoagulant uses, diabetes control, post-operative restrictions. We have a lot of patients that claim they don't take anything, but they take plenty of supplements. Supplements simply like vitamin E or CoQ10 or garlic. If they take it in higher enough doses, they have a risk of bleeding. Some other things we need to consider is our patients are not often good historians, like we mentioned, but also they know all the medications that they're taking. I mean, with technology, it's a fantastic thing. I have patients who have their medications listed on their apps or on their health apps with NYU or Mount Sinai, whichever provider they have, and they can usually look up their medications if they've forgotten them. Otherwise, we can call their pharmacies, and they usually send over a list. So we want to verify those lists, because often patients come in and they tell us that they're only taking 1 or 2 medications, and oftentimes I get the list from the pharmacy, and there's a list, maybe a page or 2. So it's important to take a look at that and take a look at the whole picture. As we move into improving periodontal communications with the patient, we want to consider using visual aids, like Emma had mentioned, Dr. Guzman. I do a lot of visual aids, not only using radiographs, but also flip charts and models that I have in my office, using tools, intraoral tools, not only on the typodont, so I can show them, after using them on the typodont, I can show them how to use it in their mouth. So they're not intimidated with how to use the instruments, because sometimes you tell them how to use it into proximal brush, it may be a little intimidating because it might be sore, it might be tender. So it's important to not only, tell the patient how to do them and show them, but they have to reciprocate so they can show us how they do it in their own mouth, so they understand what's going on. Moving on to surgical recommendations, we want to make sure that they understand that it's not the final end all. Once the surgery is done, that there's no responsibility. We want to make sure that they're able to maintain it, and maintaining is often important as doing the treatment itself. So, I mean, for example, sometimes when we have patients who are reluctant to come back for maintenance, I equate it to like an oil change. Many of our patients take care of their cars better than they take care of themselves. I have patients who religiously will go every 3 months and take care of their cars and do oil changes. But when we ask them to do 3-month maintenance for their oral health, they hem and haw and they cancel their appointments. So it's important to equate it to something, use analogies and equate it to something that's more tangible to them. So I use that often, not only in my own private practice, but at NYU where I teach. Using translators I found are very helpful. I am bilingual, but there's many dialects within the Chinese language that I'm not familiar with. So oftentimes I do use translators, or I do use the assistants in my office to help me if I struggle with that particular dialect. And if you don't have professional or you don't have staff that can help you, there are apps that you can use. And their technology is quite advanced now, where they can use almost AI to help translate. Important is you want to also have a consistent philosophy and terminology throughout your office. So oftentimes the patient may confide in your hygienist or confide in your assistant, and asks, after you have left the room, is this really necessary? Do you think this is really important? I think that's important to train your staff and have your staff cross-train this way so that there's no miscommunication. Moving along to some other case examples, surgical reluctance. When patient declines periodontal treatment, it's usually they may believe that cutting their gums may be weakening their health, overall health. So sometimes you may reframe it as, removing the infection or removing the etiology that's causing the infection. And that may put it in a little bit of perspective for them. Or I have patients who are reluctant, some Asian patients who are reluctant to have cleanings done, and they come in like every couple of years to come clean for the cleanings because they claim that after their cleaning, their last cleaning, after they had not had a cleaning for many years, that there's now more spaces between my teeth, or my teeth are now more sensitive. I'd rather not have my cleaning for a couple of years. But you have to educate our patients to let them know that it's the tartar buildup or the plaque buildup, the calculus buildup rather, that causes all the inflammation and artificially holds the tissue up. And once you remove it, it shrinks down to the level of where the bone is. So it's really important to consider that and explain it to our patients thoroughly before we start treatment, because otherwise, they'll complain and then they'll move on to the next provider, or they won't seek treatment until the next emergency. So that's really important to understand. So to enhance trust, clarity, and patient readiness, we want to work on building trust with our patient. So we want to respect their cultural values without reinforcing any common misconceptions. We want to acknowledge and listen to their fears before correcting them. So we want to take their time and listen to their perspective before we correct their viewpoint or educate them on the misconceptions of their viewpoint. We want to, like I mentioned, we want to have a consistent messaging throughout our clinical team. How can we improve readiness? We want to talk about explicitly, what are your concerns about the treatment? What specifically is scary for you? Whether it's the needle itself or whether it's the sound. I mean, there's things that we can go around that. I have patients who hate the sound of the ultrasonic unit. So I ask my patients to bring in their headphones or their noise canceling headphones, and they love it. So it's fantastic. We have, a lot of different options that way. We also want to give the patient time to make a decision when feasible, so that we can either stage the treatment or move the treatment as they're ready, as long as they're safe and they're not in danger. Cultural humility is also important. It's an ongoing learned skill over time, which is important it's hard, it takes time to learn. It's something really difficult to teach, as I try to convey this to my dental students. So it takes a little bit at a time, and it's almost like a nuance. So as we talk about all this, and I hope this has been helpful for everyone. Effective periodontal care depends not only on the diagnosis and techniques, but how well we communicate with our patients, how they trust us or engage with us as we come up with their treatment plan. So cultural and linguistic competence is a clinical necessity. So it's important. It's really important that all of you showed up this evening and shared your time with us. So I want to thank you and bring it back to Dr. Malord.
Thank you so much, Dr. Tang. I think you brought home the importance of communication, and you also brought the importance of what Dr. Guzman was saying and what I was trying to get to, which is sometimes it's the literal translation of, and that's what I'm going to start off with our panelists. And I encourage the audience to please put in the Q&A function. Please put in your questions. I will read the questions and have our panelists answer your questions. Let's start off with the provider. So we learned everything at NYU, SUNY Buffalo, and now we have to make it make sense to a patient in their native language. And yet the terms we learn are in English. In English, you could pop off the terms quickly, but in Spanish or in Haitian Creole or in the Chinese dialect, it's a little tougher. So how do we make, and Dr. Tang, I thought you brought home that point well when you said the literal translation means something about a deep dive. I'm like, oh, that's really something.
Yeah, deep
How
dive into the abyss.
how can we make it work? Make it not so scary and still make it clinically understandable to the patient. Anybody can take that question. Even you, Dr. Mensapulo. Are
Well,
you muted?
Fabiola, I think that the main thing that we have to do in all this is we have to be very sincere with our patients. We have to explain to the patients the best way of doing the treatment and give them the different options. Okay. In the case that I always tell the parent, yes, these treatments have to be done. No, they don't have to be done. Okay, this is something that will benefit your child. This was something that eventually is going to keep them out of pain, but we can't force them to do anything. We explain to them what the best treatment is, and eventually, they're the ones that make the decision on how to do, how to treat, if the tooth has an infection, we explain to them we have to put them on antibiotics. The best treatment is to take the tooth out. And what happens a lot of times, we put them on antibiotic, they don't come back. And then what happens? The swelling comes back with a vengeance. So, we have to explain to them in layman terms what could happen if we leave the tooth there, that eventually, yes, they're going to end up in the emergency room because it always happens that the swelling comes down, and Joanna can attest to this on a Saturday night when they can't get you until Monday morning and they end up in the emergency room.
Or Christmas or Thanksgiving in my case. It's always a holiday and the phone rings. Never fails. Um, anyone else with the literal translation? Again, Dr. Guzman, since I started with you, with we learned all our terms clinically in English, and yet we have to translate these and get as close as we can, the words as close as we can to their native tongue. How do we go about compensating for that?
So my experience.
Oh, I think Dr. Guzman is having internet issues. So hopefully she will join us again. Yeah, she said she was kicked off the internet. So hopefully she'll be able to join us again.
What patients understood, right? Like when it comes.
We missed the whole section of what you said because you cut off.
Okay, can you hear me now?
Yeah. So
Okay.
stop.
Yeah, I know the Verizon is hitting me. My internet got cut off.
Oh, sorry. Go ahead.
Yes. So what I was saying is that I looked up like if it existed, Spanish dental terminology. So I looked up the dictionary and I was like, okay, there are certain words that are on here. And I would start to use them as kind of tests to see what patients actually understood. And people knew when I was trying to explain, like, oh, the tooth is broken down, and they would say to me, caria. And I'm like, oh, you know what caries is? Because in Spanish, we actually say caries, right? And it's not a dental terminology. That's how we say decay in Spanish. Or, I'm trying to explain root canal and it's tratamiento de conducto, right? So it's conduction treatment, right? Nerves conduce the electricity on the tooth, right? So there's certain terminology that I was able to use that patients just understood. And it's kind of we kind of worked it as we went. When we were going on our mission trips in DR, I went to a mission trip in Mexico. I'm asking the dentist there, what terminology are you using? Right? And trying to get lived experiences of what worked for the patients. And of course, there's certain things where it's just like you're going to literally just describe what you're doing. I'm going to clean under your gums, right? I'm not saying oh, you have periodontal disease. I'm like, I'm going to clean under your gums. And I'm directly just saying that in Spanish. Voy a limpiar debajo de tu encía, right? And they understand that. So a lot of the times it doesn't have to be as difficult. And even if I'm trying to explain something, sometimes I had patients tell me what the actual terminology is. And I'm like, all right, I'm going to add that to the book.
Thank you, Dr. Guzman. Speaking of mission, we all know that the universal language is mathematics. And that's why I'm very competent with the instruments and the numbers are 150 or 1314, 151, because you go to a different country and you ask for 150, let's say in Dr. Vasquez's case, a 150S, they'll know what you're talking about. Because the instrument 150S in the Dominican Republic is a 150S in New York. So I would ask the audience to, I know that you know what a lower forceps and an upper forceps is. Okay. I would also encourage to get the numbers right because a 53R, 53L, an 88, or like the scalars, a 204S, get those numbers right. Because as you communicate with another dentist and you need help with instruments, those numbers will really save you. So that's my part about the universal language being mathematics. I think that's very helpful in medicine and dentistry. Let's talk a little bit about social media. Times are not the same. You have a double challenge. Not only do we have cultural, generational differences, but now you have social media. I'm not sure if it was Dr. Vasquez, not Dr. Vasquez, Dr. Guzman or Dr. Tang who mentioned about what they get off the internet. This root canals are poison, or this implant is poisoning my body, take it out. And where they get their facts and their information from. In my particular instance, I had a patient who came in swollen with an infection, and she's been walking around with that infection, she says, for 2 years. I said, you have two choices, a root canal or extraction. She won't do either one. So the influence of the internet. How can we, and it's a very powerful influence. We all know that.
Mhm.
But we're the practitioners. We're the ones who went to dental school. I read off some very fancy CVs and bios here. We are supposed to be the first line of information, but the internet is. How can we meet the moment? Dr. Tang, I'll start with you.
Well, just like I tell my patients, I mean, especially the ones that are super nervous about procedures, I tell them not to do a deep dive and go down the rabbit hole of TikTok and, YouTube and, whatever down the line. I give them credible websites for you to look on, and these are the only ones you're going to look on, whether it's the AAP website or the ADA website, where they have, information that is calibrated, that is legitimate, that is evidence-based, so that patients don't go down the rabbit hole where they look at the different types of procedures and look at all the bone grafts and the soft tissues, so they freak themselves out. So this way it's all animated, it's all PG rated, so they don't have to worry about it. And if they have any questions, they're more than welcome to call me and we can discuss it after the visit.
Dr. Vasquez, any thoughts? How you
Yes.
would go about explaining anything to a parent, but in your case, probably a teenager, because that's their wheelhouse.
Yes, that is their wheelhouse, and that is something that we encounter every day because you know that Dr. Google knows more than we do. Okay. So that's one thing. But like Vera was saying, we have the tools to tell the parents to go to these different places to look for information. We have the tool that as ADA members, we have our parent company. Okay, our parent, the ADA is what we all work for, right? And the ADA can give so much information to the patient. Okay. Um, Again, use all the tools that we have to tell their parents or the patients in this case to look for it, not to look for Dr. Google, because a lot of that information is false.
Thank you very much. I'm going to ask Casey, I know you're still there, and I know that we're quickly running out of time, but I really want to go to the audience. I think that they deserve some attention too, especially since they on a late evening on a cold January where the Verizon was spotty and they stuck it out with us. So let's go into the chat and see if we can get some questions or just some thoughts. As long as it's not, as in we keep it PG or even G, we're gonna get those thoughts. I see Dr. John Rathbauer. Dr. Rathbauer, welcome, welcome. After a complete discussion of the treatment options, it is important to discuss the risks and benefits, and all this after building trust with your patients. Speak from the heart and treat patients like they are your family. This is coming from, I know Dr. Rathbauer. I taught next to Dr. Rathbauer for many years. I miss you, Dr. Rathbauer, and you have always given solid advice. This is one of them. Thank you very much. Anonymous attendee, to the Spanish speakers, do you feel this for the Spanish speakers? Do you feel you need to know the country of origin of the patient? Good point. Do you feel you need to know the country of origin of the patient in order to speak to the patient? I know that I always get hung up when telling patients not to use straws after extractions because there are so many words that are used. So I'll have this for the Spanish speakers. What are your thoughts there?
Absolutely. You should know what the country of origin is. Because, like I always say, I know my Spanish in Puerto Rican, which a lot of times is, not, perfect Spanish. Okay. It's Spanglish. So other countries speak proper Spanish. In Puerto Rico, I have to say, we don't. We speak a lot of Spanglish. So it's always good to know the country of origin because there are going to be some words that if you say it the wrong way, it means something different.
Excellent and very well said. Dr. Guzman, any short thoughts on that?
Absolutely. And I started, laughing when you said straw because that is one of the ones that is like, is it a pajilla? Is it a papote? Is it a sorbete? Like there's so many different ways to say straw, and we actually use it in dentistry. So it's one of those words that is like, okay, where are you from? Because if you're from Central America or you're Dominican or you're Puerto Rican or you're from South America, you're going to say straw differently. So it definitely is important to know the country the patient is from.
Any
And I might add, Fabiola, I might add also the bottle. That's another one, okay, that is completely different in different places. It's the biberon, it's the botella, it's the teta, it's different ones in different countries. So sometimes we tell them, take them off the bottle, take them off the biberon, and they would look at you like, what are you talking about? So you have to explain to them, you have to know what the proper wording or the proper way they say it.
Well said and makes a lot of sense to me. Do you recommend any translating or interpretation services? Anybody? No. Okay. If the answer is no, then you don't know. I'm going to go on to and I know I'm going to say this wrong. Christopher Lefkelt. That was wrong. And I apologize to you, Christopher. Please accept my apologies. How do you know your interpreter you call for video translation is competent in excellent question, Christopher. Is competent in dental terminology. We have this monitor on the wall where we ask the patient to pick their language of choice to get an interpreter called up for communication, which is great. But as a provider, I wonder how competent they are, as I don't know what standards interpreters in New York State have to pass in order to work with patients while employed by an interpreter agency. So, because we don't understand. So they're using an interpreter on they're FaceTiming with an interpreter. And unless you speak that language, you really are in the dark as to is the interpreter explaining exactly how and what you want explained? So that's a good point, Christopher. Dr. Tang, you have a thought?
Yeah, I do, because we do have the Marty system at NYU, and oftentimes when I walk by, sometimes they try to describe, like we've been talking about all along. They try to describe as close as they can, but they do not have the dental terminology or the medical terminology that we need. Even when we're going through medical history or we're trying to explain something, they try to. I mean, based on what I've overheard through the translators, based on my language, they try to come as close as they can. It's not perfect, but it's better than nothing, I suppose.
Thank you, Dr. Tang. Good point as well. Um,
Yeah, I would agree with that. Where previously it was the young child, right, or the cousin or the friend who was coming to translate, and they don't know medical terminology either. So I feel like, look, we need to. It's a great question to pose because I never thought about it, right? Because we're just trusting that they're trained, right? If they're in the system, and we're in a dental office or a dental school or a hospital is using them, I just would think, oh, they're trained to know these things. But you're right, that is something that we definitely have to think about. And in terms of the question, some of our colleagues were gracious enough to respond in saying, for translating services, Dr. Rota says AMS language services as a recommendation, and Dr. Irby Tucker said propio. So PROPIO is also an interpreter service.
Thank you.
And
Dr.
the ADA has sponsored interpretation services with Cybercom.
So that's 3 suggestions that were given to the audience. Thank you. Thank you, Dr. Rothis, Dr. Tucker, and Dr. Guzman for your recommendations. Thank you. Dr. Citado wants to say this has been so interesting. Do you give out post-operative instructions, health history in Spanish? I have not, but I'm going to do it now. Dr. Vasquez, I see you shaking your head, so you want to take that one?
Absolutely. Like I said before in my presentation, we have both. We have the medical history in Spanish and in English, and we do have the post-op instructions also. So yes, we do provide it.
Excellent. I'm going to take 1 or 2 more questions and we're going to wrap up. Dr. Rothis says, when speaking with patients from another country, especially through a translator, I always explain dental conditions and procedures using basic terms. I think Dr. Tang made that good point. For example, in Spanish, periodontitis is periodontitis. So I use phrases like your gums are sick. Okay, very good. That makes a lot of sense, actually. Oh, I thought I just saw Dr. Mahone Vasquez, but I thought I did see Dr. Mahone Vasquez on
Yeah,
this.
that was the recommendation of the translation services.
Oh, okay. Thank you, Dr. Mahone Vasquez, out there in the audience. Peter Hatala. I work in an underserved area of Binghamton, New York. A hospital setting, we use an interpreter to help us communicate with our non-English speaking patients. These services are invaluable and can promote trust between the dentist and patient, even though I am not directly speaking to the patient. If you do not have an interpreter service, there are multiple apps on your phone that can help as well. Just schedule an extra 10 to 15 minutes of your chair time for the back and forth communication. And let me say this. Thank you, Dr. Hatala. I'll say this. Before the apps, I'm one of the people who graduated in the 1900s. So that was before any of it. And I had my deaf patients. I would write on a piece of paper. It worked back and forth. And she takes the paper and I take the paper. And she said, now I understand that now text is way easier. I'm not saying write back and forth. Some people don't even write anymore. All they do is type. They don't even know how to write anymore. I get it. But if you are in an underserved or in on a medical mission where internet may be spotty or there are no, like there's always a phone because I've seen some of the poorest people have basic, even a flip phone. But if that becomes a challenge, just writing back and forth will be helpful. Let me finish up with one last question and then we'll wrap up. Uh, any strategies on how to overcome unconscious biases to improve trust across? Oh, I lost that question. Hold on. Uh, 1 second. To improve trust across different cultures on the first encounter. Unconscious biases, black, white, women, in a lot of, I'll, to answer that question, anonymous attendee, I'm not going to answer the question. I'm going to give you a good example. In many cultures that have come, and I speak strictly for my experience as a practitioner, the wife will sit in the chair, I'll ask a question, and the husband is answering. So I'll ask another question, and the husband answers again. So the wife has no voice. And I really want to hear directly from my patient. And how do you tell the husband, step out of the room? That's his wife. So it all becomes, I think your question becomes not only about unconscious bias, it also becomes about open communication. The panelists' thoughts on unconscious bias and having a voice for the patient.
I'm going to try to answer this quickly. I know we want to wrap up and respect everyone's time. I would say that when it comes to unconscious biases, the first thing is recognizing that you have them when you notice them, because there's times where you have to check yourself and say, I had a perception of that patient or a perception of how this interaction was going to go, and it went differently. So my charge to you is to do your research, see more patients of those different demographics. And if you there was a question before that mentioned, how do you deal with being nervous? You don't want to say the wrong thing, right? You don't want to display your biases. If you're genuinely trying to treat someone and care for that human and care for your patients, ask the questions. Don't feel awkward. Sometimes I ask, oh, what's that design on your nail? What type of food are you consuming that's staining like that? Right? Okay, that's normal in your culture. That's cool. Tell me more about it. But now we need a combat that is causing this oral condition, right? But I feel like genuinely being curious about your patients can definitely bridge that gap. I think that we're fearful of asking those questions because we don't want to be inappropriate. But if you don't know, hey, it's best to try to get the answer from the source. It was big when it came to the office, when it came to pronouns. right? Everyone's, "Whew, I don't know what to do about that." Just ask. What do you prefer? Right. So I think about the same thing when we're asking about cultural things, things that we may not understand. If you don't mind me asking, why do you always take off your shoes when you come here? Right. And a patient may say, oh, that's a sign of respect. Right. I don't want to put my dirty shoes on your furniture. Right. So there's certain things that we could just communicate with our patient and ask those questions with genuine curiosity that, they won't think that they're judging them. And if we do, we apologize and we move on. Right. There was also the question about what if someone doesn't agree to be treated because of racial differences? Then you may not be the practice for them. Right. People have their own autonomy, they have that choice, but hopefully, do you have that referral? You know what? This may not be the place for you, but I have my colleague up the street and that could provide care because that's what we want. It may not be with me, but I want you to get care somewhere else. So that
That's
was my
why
the three
I'm
questions I saw.
absolutely about putting your photo up on your website. That way we can avoid all that. You know who's in the practice, you know how many people are in the practice. You can pick and choose if you want to go to that practice or not. Put your photo up on the website, ladies and gentlemen. That way we can avoid all these unconscious bias and uncomfortable moments. That way you could go wherever you want to go. Hey, it's all good. All
And
right. So
and
Kate,
to add to that, Fabiola, it
mm,
is, for the ones that are members, there is a member benefit. You put your picture on Find a Dentist, and the patients will find you. The patients will see who you are.
that's
So
absolutely
utilize that benefit.